Ladies, women, let's talk about endometriosis and its management. Remember, endometriosis is driven by estrogen and inflammation. So if you understand that one sentence, then slowly you are going to understand the management. Now, the tissue outside the uterus behaves like the uterine lining. It responds to hormones every single month. That means every month it swells. It bleeds microscopically. It irritates the surrounding organs and it causes chronic inflammation. Now, treatments must either reduce the inflammation, suppress the estrogen, or physically remove the lesions. Now, we usually begin conservatively. It is very important. Now, we take something like NSAIDs, like ibuprofen. They help decrease prostaglandins. Let me tell you something now. Prostaglandins are inflammatory chemicals responsible for uterine cramping and pelvic pain. So remember, they reduce pain. Yes, they do, but they do not stop the implant from growing. This is a symptom control, not a disease control. The real control starts with hormonal therapy. Now, since estrogen fuels the implant, we suppress the ovarian estrogen production. Remember, combined oral contraceptives are commonly used, especially the continuous dosing, so the patient doesn't menstruate monthly. No menstruation means less stimulation of the ectopic tissues. It is very important. Now, if pain persists, we use progestins. Let me tell you something. Progesterone counteracts estrogen. Now, it causes thinning and atrophy of both normal and ectopic endometrial tissue. Now, this reduces bleeding, it reduces inflammation, and it decreases pain intensity. Now, for more severe disease, we escalate it to the GnRH therapy. These medications suppress the pituitary gland. It lowers your LH and FSH, which dramatically decreases estrogen levels. So realistically, essentially, we create a temporary menopausal state. Now remember, pain often improves significantly, but we must monitor bone density and manage the hypoestrogenic side effect. Now, if medical therapy fails or if infertility is present, laparoscopy becomes important. Remember, surgical excision, not just burning the lesions. Remember, they remove implants completely and can improve fertility outcomes. This is both diagnostic and therapeutic. Now, hysterectomy, that is the last option, and it is considered only when childbearing is complete and symptoms are refractory. Remember, management is individualized. You consider your age, fertility goals, and pain severity and the extent of the disease. Endometriosis is chronic. We manage it long term. The goal is just not pain relief, it is restoring the function, protecting fertility, and improving the quality of life. I always come here to explain a few things to you. My name is Nurse Solomon, and I'm going to see you soon.